Hello everyone. Okay, let's dive into this. आज का हमारा high yield topic है ectopic pregnancy. Literally, this is an absolute must-know for your exams and your future clinical practice. We're going to break it down conceptually, step by step, exactly the way you need it for your NEET PG preparation. Pura focus yan rakna, guys, because every single concept we discuss today is a potential MCQ. Let's get started.
So, here is the clinical cascade we'll be covering today. Section 1 is all about the basics of ectopic pregnancy. Then, Section 2 covers risks and tubal outcomes. Section 3 is clinical features and diagnosis. And finally, Section 4 deals with management and coldocentesis. This structured flow is exactly how you need to memorize it. Dimag mein ye structure ekdam set kar lo.
All right, moving right into Section 1, Basics of Ectopic Pregnancy. We absolutely must start by laying down the physiological foundation. Normal se kya alab ho raha hai? Let's figure that out.
Okay, first fundamental concept. What is the exact role of progesterone here? You see, in an ectopic pregnancy, the corpus luteum is still secreting progesterone. Now, the levels are higher than in a normal, non-pregnant state, but definitely lesser than a normal intrauterine pregnancy. Because of this progesterone, the endometrium undergoes decidualization. But dhyan rakhna, the decidua vera doesn't differentiate normally into basalis, capsularis and paritalis like it should. And because of this abnormal differentiation, when you do an ultrasound, you see a pseudo-gestational sac. And eventually, when this decidua shuts off, it forms what we call a decidual cast. Samajh aaya? It's a very classic ultrasound finding.
Now, what's really interesting here is the stark anatomical contrast between the different sites in the fallopian tube. The absolute most common site for an ectopic is the ampulla. Q? Simply because it's the site of fertilization and it has the maximum number of mucosal folds, or plicae. The ovum literally just gets trapped in those folds. On the flip side, the least common but undeniably the most dangerous site is the interstitium. It's the narrowest part, right? But it has thick, strong myometrial support. Because of this support, the pregnancy can grow for a much longer time before it finally gives way and ruptures, leading to massive, life-threatening internal bleeding. Mark this, exam mein guaranteed question hai ye. So continuing with that logic, think about how the local anatomy directly dictates the timing of when the pregnancy terminates. In the isthmus, which is relatively narrow and rigid, it terminates the earliest, usually around 6 to 8 weeks. The ampulla is a bit wider, so it buys some time, terminating at about 8 to 10 weeks. And as we just discussed, the interstitium takes the longest, up to 12 weeks, purely because of that strong myometrial muscle holding it all together. Chronology yaad rakhni hai aapko, it's very logical.
All right, rapid-fire revision time. Take a mental screenshot of these names right now because examiners absolutely love matching questions on these eponyms. For a cervical ectopic, the new criteria is Palman, while Rubin is now considered obsolete. For an abdominal ectopic, it's the Studiform criteria, and for an ovarian ectopic, it's Spiegelberg. You just have to rote learn these names, they're straight, high-yield one-liners.
Section 2, Risks and Tubal Outcomes. We've seen where it happens, so let's smoothly transition into why it happens. What factors actually cause that fertilized ovum to get stuck in the tube?
Let's break down the etiology, and you really need to vocally emphasize this in your brain. Pelvic inflammatory disease, or PID, is the most common cause. But a previous ectopic or a history of tubal surgeries carries the highest risk overall. Please don't confuse the two in the exam. Other factors like smoking, multiple partners, and assisted reproductive technology also contribute. Ultimately, the whole shebang boils down to adhesion formation. Adhesions disrupt the normal ciliary motion in the tube and literally prevent the ovum from reaching the uterus for implantation. Wahi atak jata hai.
So, the crucial point here is understanding how contraceptives affect this risk. This is a bit tricky, so listen closely. Contraceptives decrease your overall chance of getting pregnant, period. So the absolute risk of any pregnancy drops. However, if a patient is using contraceptives and still somehow gets pregnant, meaning the contraception completely failed, the relative risk of that specific pregnancy being an ectopic shoots way up. The highest risk is with a tubal ligation failure, followed by progesterone IUCDs. Why progesterone? Because it acts as a smooth muscle relaxant which severely decreases tubal peristalsis. The tube slows down and the ovum just sits there.
Now, if the ovum is stuck in the tube, what are the possible outcomes? Two main things can happen. Number 1, tubal abortion. This is where the ectopic pregnancy is basically expelled out of the fimbrial end into the abdomen. The most common site for this to occur is the ampulla. Number 2, tubal rupture. The ectopic continuously grows and grows until the tube simply bursts under the pressure. The most common site for rupture is the isthmus. Make sure you lock in these specific anatomical sites for each distinct outcome. Moving into Section 3, Clinical Features and Diagnosis. Imagine the patient has just arrived in your emergency room. Let's build that real-world sense of clinical urgency. How are they actually going to present to you?
I want you to hardwire this classic triad into your brains right now. Amenorrhea, pain in the abdomen, and bleeding per vagina. Among these three, abdominal pain is by far your biggest red flag. It is the most specific and most consistent symptom you'll see. It's usually localized to the lower abdomen, it's unilateral, and it can feel either sharp or dull. Agar koi bhi female of reproductive age ER mein aati hai with this triad, ectopic should immediately be your top differential.
And this brilliantly illustrates how the pathophysiology of that pain changes as the condition worsens. In an unruptured ectopic, the pain is purely just from the physical stretching of the fallopian tube, and that pain signal is transmitted via spinal nerves T11, T12, and L1. But once it ruptures, oh boy, there is massive hemoperitoneum. Blood rapidly fills the abdomen. This causes generalized mid or upper abdominal pain. You will likely see the Danforth sign, which is shoulder tip pain because all that free blood is irritating the diaphragm. Plus, gravity pulls that blood down to pool in the pouch of Douglas, which presses directly on the rectum, causing a severe urge to defecate. That is pure clinical gold right there.
Paint this clinical picture in your mind. You have a crashing patient in the ward. Their urine pregnancy test is positive, they present with the classic triad, plus they are actively going into shock with orthostatic hypotension. You examine the abdomen, it's distended, you feel rigidity, guarding, and rebound tenderness. These are textbook localizing signs of a surgical acute abdomen. You palpate the uterus, and it feels enlarged because of the pregnancy hormones, but it's much smaller than the calculated period of gestation. Guys, this is the absolute classic ruptured ectopic presentation.
Now, here is a golden clinical pearl for your practical exams. You do a pervaginal exam and you elicit cervical motion tenderness, or CMT. CMT essentially tells you there is peritonitis. But wait, it happens in both severe PID and a ruptured ectopic. So how do you quickly differentiate? The simple UPT, the urine pregnancy test, is your absolute tiebreaker. CMT with a negative UPT strongly points to PID, but CMT with a positive UPT or elevated beta-HCG, that is an ectopic pregnancy until proven otherwise. All right, Section 4, Managements and Choledocentesis. The diagnosis is made, and now we must save the patient's life through immediate surgical intervention.
Let's move to and see how this builds into an algorithmic flowchart for surgical management. First step, perform a fast scan at the bedside to quickly confirm free fluid in the abdomen. From there, your route is based purely on the patient's hemodynamic stability. Vital stable Hain? Great, go for laparoscopy. Vitals unstable Hain, patient is crashing, you do not have time to set up scopes. You must proceed immediately to an open laparotomy. It's very logical, very straightforward.
Now, as a future surgeon writing ward orders, you need to know these rigid principles. If the tube has ruptured, you do a unilateral salpingectomy, irrespective of whether her family is complete or not. You are saving a life here. You don't hesitate. An oophorectomy is only done if it's an ovarian ectopic. Don't just remove the ovary unnecessarily if it's healthy. And most importantly, once the tube has ruptured, expectant management, or medical management with methotrexate is strictly contraindicated. Medical management is completely off the table.
Finally, let's understand the mechanics of a classic diagnostic procedure, choledocentesis. You introduce a syringe into the pouch of Douglas via the posterior vaginal fornix, and you aspirate. If you pull out blood and it clots inside your syringe, it just means your needle accidentally hit a normal, healthy blood vessel. But if the blood does not clot, that means it's old hemoperitoneum blood pooling from a ruptured ectopic. Why? Because that blood has already been completely depleted of its clotting factors while sitting inside the abdominal cavity. Fun to clear? Non-clotting blood essentially guarantees hemoperitoneum. So, here is a clinical thought to leave you with. Connecting these simple clinical dots, a positive UPT, recognizing the classic triad, and understanding the physiology of non-clotting blood is exactly what will make you an excellent physician. Taking that knowledge and applying it literally means the difference between life and death for a patient bleeding out in the ER. I hope this structured masterclass really cleared up the core concepts for you. Keep revising these high-yield topics, stay focused on your prep, and I'll see you in the next section.